Hello and welcome. Today we're jumping into one of the most dynamic and, frankly, historically frustrating areas of cardiology, heart failure with preserved ejection fraction, or HFpEF. Now this is the type of heart failure where the heart pumps just fine, but it's too stiff to fill up with blood properly. For the longest time, we were in a therapeutic desert with this condition, but recently, there's been an absolute explosion of research that has completely transformed the outlook. So let's get into how the game has totally changed.
So let's just start with one number that really sets the stage, 29%. That is the one-year mortality rate for patients who get diagnosed with HFpEF. It's a staggering figure, and it tells you everything you need to know about the clinical urgency here and why the breakthroughs we're about to talk about are so incredibly important.
And make no mistake, this is not some rare condition. HFpEF is a massive and growing public health challenge. We're now at a point where it accounts for more than half of all heart failure cases in the U.S. And why is that? Well, it's driven by our aging population and this rising tide of risk factors we all know about, things like hypertension, diabetes, and especially obesity.
And when you look at a diagram like this, you really start to get why HFpEF has been such a tough nut to crack for so long. It's not just one disease. It's really a complex syndrome, a collection of problems. You've got overlapping drivers, structural changes in the heart itself, widespread inflammation, cardiometabolic stress, the whole shebang. And that complexity is exactly why a single magic bullet approach just hasn't worked.
So, right off the bat, before you can even think about treating it, you have to be sure you have the right diagnosis. And that has always been the first major hurdle for clinicians. So let's take a look at how we've gotten better at cracking that code.
Here's the real challenge for a doctor in the clinic. A patient comes in with symptoms like shortness of breath, which could be a million different things. And, this is the key part, their heart pressures might look totally normal when they're just sitting there at rest. It's often only when you put them under some physical stress, like on a treadmill, that the problem actually reveals itself, so you can see how easy it is to miss.
So to solve that diagnostic puzzle, we now have these really helpful scoring systems. You can think of them as two different tools for the same job. On one hand, you've got the HFpEF algorithm. This one's more of a deep dive. It uses lots of detailed echo features and biomarker levels. It's perfect for those complex cases where you really need to be sure. Then you have the H2FpEF score, which is much simpler and faster. It just uses basic patient info, like their age and BMI, plus a couple of simple echo numbers to give you a quick probability. Both are absolutely crucial in getting from, I suspect it might be HFpEF, to, I'm confident in this diagnosis.
Okay, so you've got the diagnosis. And this, my friends, is where the story gets really, really exciting. After years and years of failed clinical trials, we have finally broken through. We're in a new era where we have not just one, but multiple pillars of therapy that are proven to make a real difference.
First up, the SGLT2 inhibitors. Now, what's wild is that this class of drugs was originally made for diabetes. They help the kidneys get rid of extra sugar and fluid. But it turns out they are fantastic for heart failure. And now they hold a strong Class 2A recommendation specifically for HFpEF.
And the evidence is just rock solid. It comes from these two huge landmark trials. You had Emperor Preserved, which showed a 21% risk reduction in major cardiac events. Then you had the Deliver trial, which backed it up with an 18% risk reduction. And you know what the key finding was in both? The benefit was overwhelmingly driven by keeping patients out of the hospital. And that is a huge deal for their quality of life.
All right, pillar number 2, this is a class of drugs called mineralocorticoid receptor antagonists, or MRAs. Now, some of these, like spironolactone, have been around for a while. But powerful new evidence, especially from a newer non-steroidal MRA, has really cemented their place as a core therapy. If you look at the data, the original TopCat trial for spironolactone was, well, it was a bit messy. The global results were kind of flat. But when they looked just at the patients from the Americas, there was a really clear benefit. Building on that, the more recent Fine Arts HF trial, using the newer drug finerenone, showed a solid 16% reduction in cardiovascular death and total heart failure events. That really locked in the value of this whole strategy.
Now for our third pillar, the ARNIs, or angiotensin receptor and neprilysin inhibitors. The main drug here is sacubitril valsartan. The evidence for this class is a little more nuanced than the first two, but it's still an absolutely critical tool for the right patient.
So the main trial, Paragon HF, was what a lot of people would call weakly positive. It just barely missed hitting its main goal.
But when researchers dug into the data, they found that certain groups, especially women and patients who are on the lower end of that preserved ejection fraction range, got a very clear and significant benefit. And that was enough for the FDA to grant an expanded indication, making it a key option in our toolkit.
And that brings us to the newest and maybe the most exciting frontier in HFpEF treatment. This really shows how much our thinking has evolved. We're now looking beyond just the heart itself, and we're starting to target the underlying metabolic problems that drive the disease, especially obesity.
So let's talk about the GLP-1 receptor agonists. You've probably heard about these as incredibly powerful weight loss medications. Well, it turns out they are an absolute game changer for that large and very distinct group of HFpEF patients who also have obesity. And the data here is just wow. The STEP HFpEF trial with semaglutide didn't just show significant weight loss, it showed huge improvements in how patients actually felt, their quality of life. Then the SUMMIT trial with tirzepatide took it even further, showing a 38% reduction in major adverse events on top of those quality of life benefits. This is a real paradigm shift. We're moving from just treating the heart to treating the whole patient.
So, okay, we've got all these new trials, all these new drugs. How does a busy clinician actually put all of this together? Well, for that, let's turn to the brand new 2025 Canadian Cardiovascular Society guidelines because they've created a fantastic, practical roadmap for us.
First, just a quick terminology update you'll see here. The new guidelines simplify things. They lump together HFpEF and what we used to call mildly reduced EF into one big category: heart failure with non-reduced ejection fraction. And their new treatment algorithm gives clinicians this really clear evidence-based pathway to follow.
And here's the new hierarchy of therapy, laid out nice and simple. You see, 2 strong recommend ratings. That's for the SGLT2 inhibitors and the MRAs. That reflects their really robust trial data. Then, you've got 2 conditional suggest ratings, one for ARNIs, because of that more nuanced evidence we talked about, and another for the GLP-1 agonists, but specifically for that subgroup of patients with obesity.
But you know, it's so important to look at all this evidence with a critical eye. And heart failure expert Dr. Gordon Moe recently brought up a great point about the ARNI data. He basically asked, is this truly evidence-based? His argument is that because the main trial wasn't a slam dunk, a suggest recommendation makes a lot more sense than a strong recommend, which, hey, is exactly where the guideline writers ended up.
And Dr. Moe also offered some important nuance on the GLP-1 data. He pointed out that when you look at a meta-analysis for heart failure admissions, the confidence interval, that's the range of uncertainty, was really wide. It almost touched the line of no effect at all. So his take is, while these drugs are incredible for weight loss and making people feel better, their direct power to prevent hospitalizations might be a little weaker than it first looks. It's a great reminder to always dig into the details.
So when you take a step back from all the details, what's the big takeaway? It's that the treatment of HFpEF has been utterly revolutionized. We have gone from an era of, frankly, therapeutic nihilism, where doctors had almost nothing to offer, to an era where we have this powerful, diverse toolkit: SGLT2 inhibitors, MRAs, ARNIs, GLP-1 agonists. These are all evidence-based options that can truly, meaningfully improve the lives of these very high-risk patients.
But of course, the evolution never stops. And that leads us to a final, really interesting question. Now that we have this incredible toolkit of medications, what's next? Will device-based therapies, things like implantable monitors that measure lung artery pressure in real time, become the next major frontier? Could this be how we finally personalize care and conquer HFpEF for good? That is the big question the field is trying to answer right now.